Hello, everyone. I'm Dr. Jennifer Hibbert, and I'm here to talk with experts about Nano Silver. And Jackie, you've had a lot of experience using the Nano Silver. Will you tell us a little bit about its history and how you're using it?
Sure. So, just to go back, I probably shouldn't have been a doctor. I was told, my mother made me go through all these dreadful assessment profiles, and I was supposed to be a chemical engineer. And I applied for chemical engineering and got in at the University of Cape Town, but then realized I wanted to do medicine, and I had to spend another year at school because nobody lets you into medicine if it's your second choice. So, but my thinking has always been chemistry. My dad used to run the metallurgy department for Rio Tinto Zim. So I was taught all of my chemistry by metallurgists. And my dad is probably one of the people that knows more about gold than most people on the planet. And he's been extracting it with and without electricity since 1965. So he's always said to me, the silver will kill the microbes, and gold is a brilliant anti-inflammatory. And we know that anyway from rheumatoid arthritis studies. So when I went into med school, I finished cum laude out of UCT, and I got a medical research council scholarship, and I did a medical biochemistry degree. And during that time, silver came up as an antimicrobial, and the prof said, "Big Pharma are never going to let this one out." Penicillin replaced it in 1940, and ever since then, they've done everything they can to suppress the knowledge that it works. And if you look at Oron Zakar's work, he has stated very clearly that silver is used as an antimicrobial in every other industry other than human medicine, because there is an alternative medicine fringe that claims it is the cure-all to everything. But he also has questioned whether Big Pharma may have had a role in suppressing how effective it is. So briefly, in 1995, I was working with HIV in London, and one of my patients called Alan, who looked like a bodybuilder with a handlebar moustache and drove a Harley Davidson and was covered in tattoos, was the only HIV patient that was not skeletal, except for Alan's friends. And Alan would say to me, "So when are you adding silver to AZT?" And I said, "Alan, you can do whatever you like. I'm a very arrogant St. Bartholomew's Hospital trained registrar in internal medicine, and that is fringe medicine, and I'm not interested." But I think Alan's probably still alive, because combination therapy would have come in while he was still alive, and he would have added his silver to that. 2003, and we had 135 nationalities working for Emirates Airlines, and the Ayurvedic medicine has had silver around for 2,000 years. So the Ayurvedic doctors were saying, should we not be trying nebulizing with silver for SARS-1, because we're deciding which cabin crew members are going to get a ventilator, which is a very difficult decision with a young person. Anyway, SARS-1 went away, and then I came back to Zimbabwe in 2016, and I met a professor of chemical pathology who was using silver in the rural areas here to get rid of cholera, typhoid, and waterborne diseases. And I started using it in my family's group in a place that's 2 hours out of town, and all of the staff were drinking silver, and all the Kaposi sarcomas went away. And then we ran out of silver for a while, because I kind of think everyone got bored, and all the Kaposi sarcomas came back. And then we reintroduced silver, and all the Kaposi sarcomas went away. And patients who were clearly non-compliant with their ARVs got better. So when SARS-2 broke in January, I decided to make a solution for myself and my family, just in case. And on the 19th of February 2020, a patient walked in, very hypoxic, and I'm sure we've all seen it when they're talking and they can't finish a sentence. Anyway, he came in, and he was a patient who had no money. And I said to him, "No, you've got to go to the state hospital, because I can't manage you in a GP clinic." Anyway, he told me he'd come from the state hospital because all the doctors and nurses were on strike. So I was stuck with this guy. And I have a fabulous mentor, a guy called Arthur Dunkley, who very sadly has just died in Cape Town. begging for ivermectin, which was not administered. And but Arthur taught me one thing, which was, if you don't know what to do something safe for an hour and go and read up on it like crazy and think. So I nebulized this guy. I nebulized myself first in front of him to show him that it was safe. I nebulized him, and I went and thought about it and thought, let's do a full blood count, let's do a chest x-ray. We've got a COVID case, don't know what to do with it. So I sent him off for that, and he walked back in 4 hours later, speaking in full sentences and flirting outrageously with the nursing staff. And I kind of figured that I couldn't keep that information to myself. So I spoke to Dr. Ingrid Landman, who is on the College of Primary Care Physicians here. We presented this data. Some of the doctors agreed with it, some were violently opposed to it. And one of the opposition things was that people said it was a heavy metal. This is true. But if you go onto Medscape, there are three kinds of heavy metals. There are toxic heavy metals, which are mercury, arsenic, cadmium, lead. There are therapeutic heavy metals, which include gold, silver, copper, aluminium. And there are trace elements, which are necessary for the way our bodies function, which include iron, zinc, magnesium. And interestingly, the most toxic metal in terms of toxicity is actually iron, because children take iron tablets and they think they're smarties. So would we withhold iron? No. The devil's in the dose. For silver, the therapeutic index is about 8,000. So you need to take 8,000 times the amount of silver that we use therapeutically to get any sort of adverse reaction. And the adverse reaction is that your skin will turn blue, which is reversible with chelating agents. So it's a remarkably safe agent, and this patient responded dramatically. A lot of doctors started using it around the country with really good effect. And one of the other doctors phoned me and said, this stuff is pseudohemoglobin. The moment you start nebulizing with silver, particularly if it's got a high particulate content, the SATs go up immediately. And it seems to either carry oxygen or it allows red cells to carry oxygen. We're not too sure what it's doing, but your saturations improve dramatically and quickly. Come the 8th of August, when we had our first wave and we were running out of oxygen and the silver wasn't holding it, we added ivermectin to silver. And I think Martin will agree. That combination is just, I hesitate to use the word miracle, because people tell me that I talk about a miracle cure. It isn't a miracle cure. You need combinations of these drugs to combat this virus. But it was named Manana Manzi by a number of our patients. And Manzi is water, and Manana is miracle. And the patients called it miracle water because they just came right. So if we actually go to the biochemistry of how Nano Silver coats a virus and how ivermectin coats a virus and how both inhibit RNA polymerase and how both inhibit RNA helicase and how silver reduces cytokines by a factor of 5-fold when used at 5 micrograms per mol, and how ivermectin seems to bind to the spike protein and cause the CD147 receptor to no longer cross-link red cells. And silver does the same. They're almost a match made in heaven. And I know Professor Mnati and Kladla, when he added ivermectin and silver together in late June, had no deaths in a 60-bed HDU ICU, where normally they would be pushing 12 bodies out the door every day. So we were very lucky to come across it. And it's almost serendipitous that Martin and I have in common that we have a BSc degree as well as a medical degree, and we're both involved in aviation medicine. And aviation medicine is all about risk-benefit analyses. And if you think with a scientific mind rather than a double-blind, randomized, placebo-controlled trial, blah, blah, mind, you will understand that at a basic biochemical level, this thing, as in COVID-19, needs to be stopped with combination therapy early with an with an antiviral effect, very much like ARVs are used in combination early in HIV, because you have to stop the virus. And if you use combination therapy early with coronavirus, our experience is that patients get better. So that's Nano Silver.
That's great. Okay, Martin, Dr. Martin Gill, please add some more information to this. That was fascinating. Thank you for sharing all of that, Dr. Stone.
Well, I'm Dr. Martin Gill, ENT surgeon in South Africa. I actually started working on silver about a year before I met Jackie, and it was through the silver supply that, in fact, I got to know Jackie. But I was using it for ENT problems. So one of them was Pseudomonas in otitis externa. And then Jackie and I got together and we had remarkable success. And I mean, Jackie's really told us everything we need to know about silver, but what I love about silver is that it works. And when you're using silver, unlike ivermectin, you've got to wait to see what happens. In front of your eyes, people start to breathe again. And it's just one of those really spectacular additions to your treatment. And it's a comfort to have silver around, because when you've got a patient who's really hypoxic, you know that in an hour's time, they're going to be better than they are now. And in 2 hours' time, they'll be better than they are in an hour's time. And that's what I love about silver.
That's amazing.
So it's short and sharp.
Thank you. Thank you. And Dr. Colleen Aldous in South Africa, please give us information from you too.
I think what's come out now is that the thinking beyond clinician science thinking is what's going to move this treatment regimen forward. Both the doctors that are on this team now have been natural scientists as well. And natural scientists have a different way of thinking. And I've been pushing for people to think beyond just double-blinded randomized control trials. And natural science doesn't have DBRCTs. All of science is much bigger than DBRCTs. And silver has been with us for centuries, millennia. So why would we want to do a DBRCT on something that has been used all the time? We haven't done DBRCTs on prednisolone in COVID. Why would we even want to do it now? And clearly, I think that it's a matter of scientific thought that is going to move this pandemic out of the way for us.
Thank you. And Dr. Stone, would you like to tell us your protocol? Because this is something people are going to want to know for each stage. Would you like to just briefly outline your protocol?
Sure. So, I mean, I still use the ABCDEF protocol in terms of a sick patient arriving. The A is the assessment. So that's very much dependent on whether they're ambulatory, how sick. I mean, you can eyeball them. If they're being carried in by their relatives, they're non-ambulant. The oximetry is the critical point. We actually do not give oxygen initially to anybody saturating over 80%. We put them on a silver nebulizer first. And as soon as the patient comes through the door, they get put on a silver nebulizer and they get given, depending on how sick they are, 0.4 to 0.6 milligrams per kilogram of ivermectin. We then draw blood for a full blood count, D-dimer, CRP, and LDH. You can add anything else you want onto those, but those are the 4 critical tests to do, and that's the B, that's blood. Okay. So A is assess your patient and initiate treatment. B is take your bloods. It's also breathing. So if they're under 80%, we put them onto oxygen. We use a nebulizer mask though, so they're on oxygen and silver. If they're over 80%, they're only on silver. We have limited resources. We don't have enough oxygen. C is to cannulate the patient. If they're particularly sick, we give them ceftriaxone and dexamethasone as a intravenous bolus. If they are able to swallow, we're now giving methylprednisolone as opposed to dexamethasone because it seems to accumulate better in the lung and it seems to do better. Then the D, there's a number of Ds. The one D is diabetes. We check what the glucose is because a diabetic patient needs aggressive control of their sugar. The next D is the drugs, and we double check what we've given. And the combination therapy is, we call it SIDS, which is silver, have they got it? Ivermectin at an adequate dose, doxycycline, D3, zinc. And the one thing I haven't gone through is that right at the beginning, when we were looking at candidate drugs in Zimbabwe, we looked at zinc because zinc inhibits RNA polymerase in a dose-dependent manner. So we looked at drugs that would allow zinc into the cell. And those are hydroxychloroquine, chloroquine, doxycycline, ivermectin, and quercetin, which seem to be the drugs that work. And in our experience, and we are malaria doctors, we had 135,000 cases of malaria year before last. Interestingly, since we started ivermectin, we've had a 79% drop in malaria cases, which is a very good indication that everyone's using ivermectin, because if a mosquito bites someone who's taking ivermectin, it can't reproduce. So the best side effect of everyone taking ivermectin is that we've got a fraction of the mosquitoes we had the year before last. But anyway, getting back to the SIDS, we have now introduced with this Delta variant, early patients are all getting hydroxychloroquine as well. So we've gone for quintuple therapy because your zinc ionophores are hydroxychloroquine, ivermectin, doxycycline, and we're giving zinc at least 40 milligrams BD. And that combination really seems to hammer the virus. So when you're thinking of your drugs, you need to think antiviral, anti-inflammatory, antithrombotic. So any patient who is high risk, particularly patients who have stents or who have cardiac disease, they get aspirin and clopidogrel early. If we get a raised D-dimer, we give them a shot of enoxaparin and we give them Xarelto to go home on. Our patients only come to our unit for 6 hours, okay? Then that's the D. The next D is actually doctor, because most of this is handled by nurses up until this stage. We have nurses that have worked for a year, and 2 of my nurses, I don't even have to tell what to do anymore. They just phone me and say, right, what do you want to do with these results? So by the time we've got to the doctor, we've now got the blood results. If the CRP is over 20 and the patient is hypoxic, we give prednisolone at 1 milligram per kilogram per day. If the D-dimer is raised, we add in enoxaparin followed by Xarelto. E is exit from the unit. You have to think about the patient exiting the unit the moment they walk in. So one of the ways to keep the family occupied is to tell them, go and organize home nursing and go and organize home oxygen. And we give them the numbers and they go away and do that. So when they come back 4 hours later, we're ready to discharge the patient at 6 hours on home oxygen and on home nursing. On Saturday night, I broke my mantra, which is do not admit. And I had a family that had been battling with a patient for about 10 days. And I'd been there every single day. And I said, look, one of the hospitals is doing outpatient oxygen, outpatient red zone. Let's send him there for the night because the physician that's on call tonight actually cares. Unfortunately, what I didn't know was that physician had been called to another hospital and that patient was admitted and was dead within an hour. And it's my only death in this wave. And every time I refer a patient to hospital, they die. And that's partly because the physicians pop in for a cost of $800 US visit for 15 minutes to assess the patient. And the nurses are so burnt out, so poorly trained, and they've got this attitude that everyone's going to die from COVID anyway, that they don't actually care enough to look after the patients. So the best people to care for the patients are their families. We allow their families into our units, and they've been exposed anyway. And the families come in and they take their relatives home and they look after them far better than any nurse could. So the E is exit from the unit, which is planned the moment they walk through the door. And then the F is families. Everybody in the family must receive post-exposure prophylaxis. We think we're seeing resistance to ivermectin in Zimbabwe. We've been using it extensively since December. So the post-exposure prophylaxis is again SIDS. They nebulize with silver. They get ivermectin at 0.2 to 0.6 per kilo, depending on the level of exposure, depending on the risk. They get doxycycline for 5 days. We did write our protocol with Martin to say that the ivermectin would be given on day 1, 3, and 5. We've changed that here. We're giving them 5 days of ivermectin because Zimbabwe is the biggest importer of ivermectin in the world. We don't have a shortage of it, okay? So we dish it out rather than have to see the patient again. They get vitamin D3 at 6,000 international units a day, and they get vitamin C at 500 TDS, and they get zinc at 40 once a day as a prophylaxis protocol. So the A, B, C, D, E, F seems to both stop. It contains the family spread, but the patients generally go home in 6 hours with home nursing and home oxygen.
That's so practical. Jackie, what is the concentration of the Nano Silver that you have them nebulizing?
So when you understand silver, you have to understand that there's an ionic fraction and that there's a nano silver fraction. And when you're actually making it, and this is where the whole biochemistry thing comes in, is that when you make ionic silver, it will get to 25 micrograms per mil, and then it will start to supersaturate. So the ionic fraction, it's important to understand that ionic silver will bind to phosphate. Silver phosphate is one of the most insoluble compounds in the world. And RNA and DNA has a phosphate backbone. So ionic silver, once it's bound to RNA or DNA, completely scrambles the nucleus. If you look at it under an electron microscope, everything just clumps. And what we do know is that when you use ionic silver in a bacterial infection, depending on the size of the capsule, you will get at about 25 micrograms per ml, it'll inhibit E. coli. You need to get to 50 to inhibit staph because it's got a bigger capsule. You need to get 75 to inhibit candida. So the ionic fraction is very important for preventing replication. Whether you're a virus, a bacteria, a candida, a fungus, or a parasite. The nanoparticulate fraction will form once you reach 25 micrograms per ml. You will get dimers, and a dimer is about 600 picometers, and then you'll get to 1 nanometer particles. What Oren Zakar did was he worked out that to coat the spike protein, you needed particles of 8 to 12 nanometers, and he has made us a solution that we do use. And my nurses will phone me saying, "Doc, we've got a really sick one. Please give me the pure gold," because it actually is, it's a yellow color. So nanoparticulate silver coats spike proteins, but in addition, it acts as a slow release drug for ionic silver, because ionic and nano will be in equilibrium. And the hotter and the warmer your solution, the more ionic is going to come off the nanoparticles. So they actually work quite differently, but the ionic, in addition, is well known in vitro, in a test tube, to reduce interleukin-6 by a factor of 5 to 6-fold, and it reduces TNF-alpha dramatically. So as I understand it, the ionic stops viral replication, the ionic reduces cytokines, the nano releases ionic, but the nano is coating the spike protein. The nano is also, by coating the spike protein, causing the clumping that's happening with the erythrocytes to stop, because the CD147 receptor is no longer cross-linking red cells. But the most important thing about the nano is that it appears to be carrying oxygen. And we know that in industry, they use nanoparticulate silver to transport oxygen to carbon tubules to make carbon dioxide. Because the moment you put the patient on the silver, the sats go up.
Interesting.
And you can't explain that by killing virus or reducing cytokines.
That's great. Great information. Thank you very much.
And it doesn't drop off, which is the reason why I think it's staying around carrying oxygen.
How long does it stay on for?
We nebulize continually where we need to, but otherwise it's 3 to 4 times a day. And it's titrate to effect. If the patient starts desaturating, put them back on. The other thing that I would say, though, is in the early days when we only had the silver, and especially with the incredibly sick ones, we would get a result. So the guy that came in at 14%, we got up to 77%, and we held him there for about 6 hours. And then he just went into cardiac failure, renal failure, everything just collapsed. When you give ivermectin with silver, ivermectin works about 4 to 6 hours later. So silver gets you your immediate effect, but silver and ivermectin in combination result in the long-term recovery.
Yeah, okay. Right, that makes sense.
I don't think there's such a thing as monotherapy for COVID-19. We need multiple effective drugs early.
Yes.
And that's just like HIV. It's just like Helicobacter. It's just like TB. I don't have any idea why we are not following the basic principles of infectious disease. We were taught, and I'll try and be polite here because the person that taught me this was not polite, but the guy who was in charge of infectious disease at Cape Town said the decision is whether or not to treat. Once you decide to treat with maximum dose with multiple agents. That was 1980. And everybody seems to have forgotten that. Everybody is so terrified of regulators and FDAs and MCASs and SAPRAs that we are tiptoeing around with homeopathic doses when we're facing something that's coming at us with ground-to-air missiles, AK-47s and FNs, and we're sitting there with a pea shooter. I mean, really.
I ask Jackie something. The question that's been asked of me about a couple of times about silver is, what about lung fibrosis as a result of silver? Can we just clarify that point?
So if you look at people who have been exposed to nano silver in industry, if you look at their lungs under a microscope, there is an increased inflammatory response. But these are people that are exposed on a daily basis for years. These are not people who get 5 to 10, maybe 15 days of silver as a single blast, okay? So the no observable adverse effect level, the NOAEL for silver, is about, and we are giving 25 micrograms per ml. Oron silver is 105 micrograms per ml. You will need to give 1,000 bottles of the stuff before you see fibrosis of the lung. So sure, in people who are working in industry where they're making nano silver and they're exposed to it, you do get some fibrosis, but they're exposed to high doses over a long period of time. The short blast is nothing. And I think it's one of those things as well, a bit like ivermectin, where people will find anything negative to say. If you look at studies where they've taken rats and exposed them to very high doses, and these doses are like over 100 times what we're giving, you do see some lung fibrosis. But when you do real life studies, nobody, with asbestosis, we know that people get reactions to asbestosis because we see people with plaques and we see people who get cancers. Mm-hmm. I am desperately trying to find someone who's died from silver because I need a percentage, okay? And nobody will die, okay? And nobody gets lung failure and nobody's in respiratory failure. So I need at least one.
Don't even say that. But that's so good to hear. Thank you so much. This is so enlightening. And we need people to listen and just to start thinking more like scientists. to make this all come together and get everybody healthy. So thank you so much, all of you, for sharing all of your brilliance with me today. Thank you for being here.